Good morning, ladies and gentlemen. So the title of my talk today is Degenerative Mitral Valve Disease. So the mitral valve complex is made up of the mitral annulus, the anterior and posterior leaflets, the posteromedial and anterolateral papillary muscles, the chordae tendineae, the LV, and the LA walls. This is a 3D zoom or 3D narrow angle data set of the mitral valve as viewed from the left atrial perspective, often called the surgeon's view. The aortic valve is in the 12 o'clock position, which is the convention. You can see here that the anterior leaflet is over here and the posterior leaflet is down here. Now the posterior leaflet is divided up into scallops, P1, P2, P3. The anterior leaflet does not really have scallops. However, it is named according to the adjacent posterior leaflet. So we have A1, A2, and A3. This is the aortic mitral curtain, and this is the coaptation of the two leaflets with the commissures at the sides here. Remember that the mitral annulus is saddle-shaped, and the saddle shape allows the mitral valve to coapt with reduced stress. You can almost see that this saddle shape is like a Pringles chip. And you can appreciate looking at these models how much stress the mitral valve must be going under. And with the help of the saddle shape, it's able to do this type of work. The coaptation zone is also an important anatomical feature of the mitral valve that you need to know about. As shown here, the leaflet is made up of a smooth zone and a rough zone. And you can see that coaptation actually takes place in the rough zone. And the coaptation reserve is about 8 millimeters. This is the coaptation reserve under normal circumstances. Of course, if the left ventricle becomes dilated and the annulus dilates, papillary muscles move apart, that coaptation reserve can diminish with pathology. This image here shows you the etiologies of mitral regurgitation. You can have primary mitral regurgitation, secondary mitral regurgitation, or a mixed pathology. Primary mitral regurgitation includes degenerative mitral valve disease, which is the topic of this talk, and that includes prolapse, flail, ruptured, elongated chordae. You can also have degenerative calcification and thickening of the leaflets causing primary mitral regurgitation. Primary mitral regurgitation can also be caused by endocarditis, perforation of the leaflets, inflammatory pathologies such as rheumatic heart disease, radiation, drug-induced. You can also have congenital causes, including cleft and parachute valve. Secondary mitral regurgitation is generally caused by annular dilation with papillary muscle displacement and dilation of the left ventricle. You can see this in both ischemic and non-ischemic cardiomyopathies. You can also get annular dilation based on atrial fibrillation, secondary to left atrial dilation, and then subsequently annular dilation. And of course, you can have mixed pathologies where a person can have both primary and secondary etiologies for their mitral regurgitation. Now, this is Carpentier's classification of mitral regurgitation mechanism, and he divides mechanism of mitral regurgitation into 3 different types. You can see in type 1, there's normal leaflet motion, where you can have annular dilation, you can have leaflet perforation, but the motion of the leaflets is normal. In type 2 mitral regurgitation, you can have excessive or increased leaflet motion. You can see this in ruptured chordae, elongated chordae, and or papillary muscle, or even ruptured papillary muscle. And here's a couple of examples. This is an example of a flail leaflet, an extensive billowing and prolapse of the mitral leaflets causing mitral regurgitation. The type 3 form of mitral regurgitation can be either restricted, called type 3A, restricted opening, or restricted closure, called type 3B. Restricted opening is typically seen in pathologies such as mitral stenosis, and restricted opening can be seen in pathologies such as ventricular dilation with wall motion abnormalities, and we can see that in ischemic mitral regurgitation. So this image here you've seen before on a previous slide. This is just to show you how we look at the mitral valve from the left atrial perspective. The surgeon's view, we appreciate the anterior leaflet here, the posterior leaflet here. But when we look at the mitral valve on transesophageal echocardiography, it is really in this position here. The TEE probe comes down here, and you get A1, P1, A2, P2, A3, P3. Perhaps easier to understand this with this image here. You can see the TEE probe traveling down the esophagus, and this is the first point at which it hits the mitral valve, point A, where you're crossing A1, P1. Notice this is like a mid-esophageal four-chamber view with the aortic valve in view. And then as we move further down the esophagus at position B, you're cutting through A2, P2. Notice there's no aortic valve here. And then position 3, A3, P3. And this here is a very posterior position. So sometimes it's actually difficult to see the leaflets clearly here. But you will notice when you put the probe down into the esophagus, this is very posterior. You can also view the mitral valve at the same level and just changing your angles. So the mid-esophageal four-chamber view is at 0 degrees with A2, P2 visible. The 45-degree angle, 60-degree angle, and 90-degree angles are all important because they have a landmark off on the left atrial appendage. And when you see the left atrial appendage, you know that you're close to A1, P1. Often the coronary sinus is seen on the other side, and that is where A3, P3 are located. So these landmarks can be very helpful when you're doing transesophageal echo to determine what part of the valve, which leaflet is abnormal. If you look at the commissural view, another important view, you can appreciate that there are three leaflets here. You are crossing P1, A2, and P3. And I'll show you more about this in the upcoming slides. This here is the long axis view, and you can see with the long axis view, you can see the aortic valve and the posterior part of the mitral valve. That's because you are crossing, it's approximately 135 degrees, but you are crossing the aortic valve and the middle of the mitral valve. So in this position, you see both A2 and P2. So here are some examples. This is a mid-esophageal four-chamber view at 0 degrees. And you can see that there is no aortic valve here. And you're crossing at A2 and P2. Sometimes in this view, you can catch other leaflets, but for the most part, you're seeing A2 and P2. This is the commissural view. Notice this hanging leaflet here. Notice also that the left atrial appendage is in view. And with the left atrial appendage in view, you know you are next to P1. So this is spot 1, 2, and 3. P1, A2, P3. Very important view to remember. Also, notice how this view actually cuts across the coaptation line of the mitral valve. So you can understand how you're crossing P3, A2, and P1. Here's the 90-degree view approximately, so 80 to 100. And you can see here already there's the coronary sinus, and we said that the coronary sinus is close to A3 and P3. So this leaflet here is P3. And the leaflets here, you might actually be seeing more than one leaflet. And in this case, it's probably A1, A2. So this side is a little more difficult to assess, but you can appreciate P3 in this view. And finally, the long axis view. This is the mid-esophageal long axis at approximately 125 to 135 degrees. And you can see how it's crossing the aortic valve and crossing A2 and P2. So typically in this view, you see the A2 and P2 leaflets. This is the transgastric view of the mitral valve. You can see that the TEE probe is positioned such that you are actually cutting at the short axis of the left ventricle. And you can appreciate here, the aortic valve actually would come up here if you pull the probe up out of the above and towards the mouth. So this is the anterior leaflet, and this here is the posterior leaflet. Now, one of the things that you will be called upon to do in real life and also in the exam is to identify the culprit scallop. So if you have a patient with degenerative mitral valve disease, prolapse, moderate or more mitral regurgitation, you might get asked to do a transesophageal echo, or you might be shown a transesophageal echo on your exam, and you need to be able to tell where the pathology is. So a couple of clues to assessing these echoes is, first, when you assess the mid-esophageal four-chamber view, ask yourself, is this the anterior leaflet or the posterior leaflet that is prolapsing or flail? And then look at the commissural view and ask yourself, is this position 3, is this position 2, or is this position 1? Is the pathology located in position 3, 2, or 1? Let's look at some examples. So case number 1, identify the prolapsing scallop. So here you can see a mid-esophageal four-chamber view, and you can tell that there is pathology here. This leaflet is actually close to the aorta. As you remember, the aortic valve is actually over here. So this is the anterior leaflet. So the pathology must be in the posterior leaflet. You can see there is, you get the sense that there's prolapse happening in the posterior leaflet here. So the pathology is posterior, as you can see here. Now, this is the same patient. We are now at a 60-degree commissural view. You can see the appendage here. And the question here is the pathology in position 3, 2, or 1? Remember that this is position 1 here, close to the appendage. This is position 2, and this is position 3. And typically, you have P1, A2, P3. So it looks like this is a P1 prolapse. And as we said, position 1. And if you look at the 3D data set, this is once again the mitral valve viewed from the left atrial perspective, aortic valve in the 12 o'clock position. This is a P1 prolapse. Remember, A1, A2, A3. Left atrial appendage is over here, P1, P2, P3. So 3D, in this case, 3D echo and 2D echo are complementary because you really need both to be able to make an adequate assessment of the valve. So let's look at another example. This is case 2. Mid-esophageal four-chamber view. You can see the pathologies in the posterior leaflet. Not only that, but you can also appreciate that there is probably a ruptured cord right here, if you watch very carefully. Also, with color Doppler, you can appreciate that there is anteriorly directed MR jet. And an anteriorly directed MR jet tells you that there's pathology in the posterior leaflet. So that fits with what we said before, that this is a mid-esophageal four-chamber view with pathology, perhaps flail, in the posterior leaflet. What about this view here? This is the 60-degree view. You can see the hanging leaflet here, left atrial appendage, coronary sinus. And this here is P1, A2, P3. The pathology we said was posterior. You can see both the anterior and posterior leaflet here in this position. The leaflet up on top there actually is, looks like it's prolapsing. So that is position 2, and it's the posterior leaflet. So here we can see from the 3D echo image here that it is P2 position and a P2 flail. This here is actually a ruptured cord, what I'm pointing to here. So P2 flail. This is just a model of the mitral valve. There is software available where you can actually model the mitral valve, and that can also help you assess where the prolapse or flail is happening. Let's try another case. So this is a mid-esophageal four-chamber view, and you can appreciate that the pathology doesn't seem to be in the plane that you are imaging. However, there is something happening in the back here. And you can obviously also see that there is significant regurgitation. However, it doesn't seem to be occurring at the point where you are imaging. And here, this is the 60-degree view. So again, the commissural view, where you see a bit of the left atrial appendage here. You see the coronary sinus here, position 1, position 2, position 3. So this is telling you P1, A2, P3. So it looks like the pathology is in P3. And you can appreciate with the MR jet also that the pathology appears to be P3. P1, A2, P3. And then this helps you also the long axis views. And you can appreciate that this is A2 and P2 because you can see the aortic valve. The pathology is not involving A2 and P2. And in fact, you can actually see the ruptured cord in the background there if you look very carefully. So pathology is not involving P2. It is localized to the third location. It's a P3 pathology. And with 3D echo, you can appreciate, this is actually a very old 3D echo, but you can appreciate the flail P3 leaflet. And this corresponds with the tiny ruptured cord that we were visualizing in some of those 2D planes. Now, the reason why we are able to see such good images of the mitral valve, and this has actually revolutionized the way we assess the mitral valve, that is because of the matrix TEE probe, which was only invented less than 15 years ago. This is actually one of the first images that was taken way back in 2007, 2008 with the matrix TEE probe. One more case, actually two more cases. This is case 4. So here's a mid-esophageal 4-chamber view. Again, always ask your question at this level. Is it an anterior or a posterior problem? And you can see again, anterior leaflet close to the aortic valve here. The pathology appears to be in the posterior leaflet. This leaflet actually looks very myxomatous, thickened, and in fact, the tricuspid valve also appears myxomatous and thickened. So the pathology is in the posterior leaflet. Now, what is interesting to note here, and we'll just go over this again, is that when you see the aortic valve, remember the TE probe higher up in the esophagus, you are cutting A1 and P1 in the 4-chamber view. It's in the second position and in the third position when you don't see the aortic valve that you'll be cutting P2 or P3, A2, A3. And that's important in this case because you see we're at the mid-esophageal 4-chamber view. We don't see the aortic valve. So it's most likely that this pathology does not involve P1. This pathology likely involves P2 or P3 or both. Here you can see the regurgitation jet of the mitral regurgitation jet. And as a matter of fact, it is rolling around the left atrium. You actually see it on this side here too. So that's severe mitral regurgitation. Again, it is anteriorly directed, corresponding with the posterior prolapse. What about this view? How does it help us? Well, this is the 80-degree view. You can see coronary sinus here. You can see the left atrial appendage here. And remember, where you see the left atrial appendage, P1 is right here. So this pathology does not involve P1. If you look at the 3D data set here, you can appreciate that there's definitely P2 prolapse. And there's also some involvement of P3. So case 5, I think this is our final case. This is a mid-esophageal 4-chamber view. And you can appreciate here that the pathology again is in the posterior leaflet. There's also thickening of that posterior leaflet. Once again, the jet is directed, anteriorly directed, which corresponds with the pathology being in the posterior leaflet. If you look at the commissural view, which is what this is, about 70 degrees in this case, there's a left atrial appendage here, there's the coronary sinus here, there's P1 here, A2, P3. And if you look carefully at this leaflet here, the P3 is actually flail. So this is position 3. And this additional view suggests to you, this is the left atrial appendage. And remember, wherever you see the left atrial appendage, you can see P1. So P1 is not involved. And indeed, you have a P3 flail. And the segment that we saw at the very beginning in the mid-esophageal 4-chamber view, that was the P2. So P2 prolapse with P3 flail. So for your exams, you will need to be able to identify what scallop is involved. You will be given a TEE image along with regurgitation, and you could be asked which scallop is the abnormal, or which scallop is causing the problem. So the landscape of degenerative mitral valve disease is multifaceted. You can see here, these are all examples of mitral valves in the degenerative mitral valve disease spectrum. You go all the way from Barlow's disease, where there's diffuse myxomatous thickening of the leaflets, to fibroelastic deficiency. In this case, the leaflet's very transparent looking with single scallop prolapse. Now, some people believe that fibroelastic deficiency and Barlow disease are two separate entities, but it is also reported that these might all be part of a spectrum. We're looking at severely myxomatous thickened leaflets, and then leaflet prolapse, maybe 1.5 leaflet prolapse. You can have multi-leaflet prolapse with billowing, flail scallops, and even commissural flail, and then P2 flail, as you can see the cord here, ruptured cord here with billowing as well, and then here no myxomatous changes in the valve. This here, I just wanted to show you an example of a commissural prolapse. You can see aortic valve in the 12 o'clock position, anterior posterior leaflets. There's the commissure that appears to be prolapsing. And this is just using a variety of different techniques, true view and glass. And you can see that changing the light allows you to actually see the prolapse much more clearly. This is 3D narrow angle color with tissue transparency. And you can appreciate the color jet from the commissure prolapse. Just to illustrate to you, this is the anterior leaflet, that's the posterior leaflet, and here's the commissural leaflet. So it does exist. And as I was mentioning to you before on a previous slide, this spectrum of degenerative mitral valve disease, from fibroelastic deficiency all the way to Barlow's disease. If you look at this case here, you can see clearly that there's a P2 flail. You can see that in the long axis view. You can also appreciate the ruptured cord here. In this patient, again, the color is directed away from the pathology. You can appreciate that here, anteriorly directed color jet with associated P2 flail. This is the 3D. And if you look at intraoperatively, you can appreciate the surgeon here is going to show us the pathology. In this same patient, is taking out that P2 scallop, and you can appreciate those are the ruptured cords. There are actually two of them there. Here's a 42-year-old lady who complains of decreased exercise capacity of recent duration. You can see on her echo, there's billowing, thickening of the mitral valve leaflets. Probably moderate mitral regurgitation, but not enough data is given here for quantification of MR, but definitely billowing thickened leaflets with extensive prolapse. This is the disease that we call Barlow's disease, where there's excess leaflet tissue with billowing, thickened leaflets, and elongated chordae with large annulus. This is actually an intraoperative view of what they could see in the OR. You can see the leaflets are huge. That's the anterior leaflet that was just pulled out there with excessive tissue. Now the surgeon's going to pull out the posterior leaflet. You can see the leaflet is giant, along with lots of thickening of the tissue, lots of redundant cords. This is Barlow disease. So to be more specific about the difference between Barlow disease and fibroelastic deficiency, I put a table up here for you. The fibroelastic deficiency is typically seen in the older age group when compared to Barlow's. History of mitral regurgitation in patients with fibroelastic deficiency tends to be less than 5 years, whereas Barlow disease tends to go on for a long period of time before patients present. Annular dilation is seen more in patients with Barlow disease. Leaflet tissue in fibroelastic deficiency tends to be thin, transparent, without excess tissue, whereas in Barlow's disease, you tend to get the thickened, diffuse excess tissue. Segmental distribution tends to be single segment in fibroelastic deficiency, whereas in Barlow's disease, you tend to get multi-segmental disease. You can have thin and ruptured cords in fibroelastic deficiency, whereas you tend to get irregular, elongated cords in Barlow disease. And Barlow disease is often associated with cleft-like indentations, and we'll talk a little bit more about the arrhythmias. It's important to note here that in the guidelines for primary mitral regurgitation, in two spots it is mentioned that the likelihood of a durable repair influences what you end up doing with the patient. If the patient is asymptomatic with severe mitral regurgitation, LV ejection fraction is greater than 60%, end systolic diameter is less than 40 millimeters, and there's a likelihood of durable repair of more than 95% with a mortality of less than 1%, you would consider mitral valve repair in these patients with a class 2A indication. And echo can help you assess whether the repair is durable or not, and or at least partially help you. And we'll go through that in the next slide or two. And the same consideration is also, or the same is taken into account in patients who have symptomatic severe mitral regurgitation with ejection fraction less than 30%. In order to decide whether these patients should go for surgery because they are higher risk, you do need to consider the likelihood of a durable repair. And if there is, you think there is a likelihood of durable repair, then these patients have a class 2B indication for surgery. So these are just some of the different surgical techniques, just so that you are aware. You can have triangular resection, annuloplasty ring, quadrangular resection with annuloplasty, artificial cords with annuloplasty, and with anterior prolapses, you can also have repair with artificial cords, and you can also get commissural repairs with commissuroplasty. This is a study that was done by a group of surgeons trying to put together a score which would tell you whether a repair is going to be simple or complex. And it's interesting to see that if you have a single scallop involvement and that single scallop is a posterior leaflet, then the repair is going to be simple, as you can see here. If you have an anterior scallop that is diseased or flail or prolapsed and requires repair, that repair is going to be more complicated. It involves an anterior leaflet. If you have a commissural prolapse, it's more complicated. Any leaflet restriction is more complicated. Annular calcification is more complicated. And as you add up these numbers, the complexity increases. And what they found was that the score of more than 5 it suggested a most complex lesion for repair. This is just to show you the different measurements that we can now make with 3D echocardiography, but we do not know exactly how to use these in clinical practice yet. You can obtain diameters, volume of prolapse, annulus height, coaptation length, and so forth. Finally, my last couple of slides, wanted to talk to you a little bit about mitral annular disjunction. This is a pathology that we have actually known about for 30 years, but only recently with the pathologists in Italy and also with the availability of MRI has it been realized that we can actually diagnose this pathology. And we're only starting to relearn about this again. So mitral annular disjunction is characterized by detachment of the annulus from the ventricular myocardium. And you can appreciate it mostly on the long axis view, as you can see here, how the leaflet is bouncing backwards. The diagnosis can really only be made in systole, and there's an association between mitral annulus disjunction and mitral valve prolapse in about 80% of cases. There's also association with ventricular arrhythmias, sudden death, and papillary muscle fibrosis. Just to look at the pathology here, this is the leaflet. This is the annulus. So this is no mitral annulus disjunction. Here, there is mitral annulus disjunction. This is the leaflet, and you see how the annulus is down here. So there is a detachment of the annulus from the ventricular myocardium. So here, this is the spectrum of mitral annular disjunction as we know it today. We're talking about the systolic movement of the annulus that you can see on the long axis views. These people can also have ventricular ectopy. And one of the findings on echocardiography, which is also typical in this disease, is what we call the Pickelhaube sign. And you can see it here on 2D transthoracic echo. This high velocity systolic signal on tissue Doppler has been shown to be a risk factor for malignant mitral valve prolapse syndrome. And again, these patients can also get LGE in the papillary muscles and sometimes even in the inferobasal wall. And with that, I would like to conclude this presentation.